There are multiple sex and gender aspects that are relevant in relation to COVID-19 vaccines, both in terms of clinical research and development of vaccines, but also with respect to distribution and rollout. But once again, we have witnessed how these important dimensions were forgotten in the process. As research by us at Gendro and others have shown, most clinical trials, including those of vaccines, fail to pay sufficient attention to possible sex differences in vaccine efficacy or experiences of side events, and attention to gender and other equity dimensions in policies and efforts related to vaccine communication, prioritization, or delivery have been inadequate. But it's never too late. And while we may not solve the entire problem today at this webinar, I'm very much hoping that we can have a candid but forward-looking discussion on what needs to be done, drawing attention on challenges and opportunities around collection of gender data, covering issues related to sex disaggregated data on safety and efficacy, and gender-sensitive evidence on acceptability and uptake, as well to use of data, for example, in evaluation by regulatory agencies, in policy decision-making processes, and in science communication to wider audience. Most importantly, I hope that we can focus our conversation on what can be done by various actors and stakeholders, and what can we do better collectively to address sex and gender dimensions in vaccine and pharmaceutical research and development, policy making, and science communication processes, having an inclusive and intersectional approach that also takes into account the specific needs and experiences of not only women and men, but also pregnant and lactating women and men of diverse sexual orientation, gender identities, and diverse gender expressions. We have an impressive line of speakers and panelists with a breadth of experience and a wealth of knowledge from different areas and different parts of the world. And we very much welcome you to join our conversation and share your stories at the end of the session when we have an opportunity for question and answers. So without further ado, I have the great pleasure to introduce you our first speaker, Tracy Goodman. Tracy comes with more than 20 years of experience in World Health Organization, is a gender focal point, and currently the team lead for the life course and integration team in WHO's Department of Immunization, Vaccines, and Biologicals, and again is a great advocate for gender responsive vaccination programs. So very much welcome, Tracy. The floor is yours.
Thank you, Sharon. Can I just check that I'm projecting for everyone?
Yes.
Yes.
Okay, great. I'm really happy to be part of this webinar today and to give a short presentation about the sex and gender considerations related to COVID vaccines. As I'm sure this audience is well aware, from the very beginning of the COVID-19 pandemic, gender was highlighted as an important issue. There were some very good statements about the need of a gender lens and the differential impacts on men and women. Unfortunately, these good words have not necessarily been translated into action. This slide shows a recent analysis of COVID-19 health policies from 76 different countries. And the researchers assessed the extent to which gender had been incorporated into those policies across different areas of health policy. And you'll see that, unfortunately, vaccination was assessed as being 91% gender blind, essentially almost completely gender blind. For WHO's global policies on COVID-19 vaccines, we are trying to do better. And to apply a gender lens, we developed a background paper examining gender-related issues and made 6 recommendations. And this was discussed by our advisory committee that helps WHO formulate our vaccine positions and recommendations. I've given you the link here in the slide. Co-author is Shirin, and I really encourage you to have a look at the paper. It goes in much more detail than I'll be able to cover in a short presentation of just 10 minutes. So that's there for your reference. So I'm going to walk you through these different recommendations. The first recommendation is that epidemiological data must be disaggregated, and at a minimum by sex and age. There are gender differences in the incidence, severity of COVID-19, morbidity and mortality. And also these factors intersect with other variables like geography or occupations and over time. While men and women are equally infected by COVID-19, men's outcomes are worse. This is a slide showing you the clinical pathways. I just touch on it briefly, but more men are admitted to hospital and ICU units, and mortality is higher among men. The important thing to note in this slide is also how few countries are collecting or reporting sex disaggregated data. Look along the bottom axis if you can see it there. Even for the outcome of deaths, we have only 107 countries reporting. That's out of 194 countries in the world. It's almost just 50%. And for other indicators like vaccination, it's much smaller, 38 and so on. So there really is a need for more data to be made available. The second recommendation is that vaccine research and development must be designed to capture gender differences. There are known biological differences in the immune responses of men and women. Females exhibit greater humoral and cell-mediated immune responses. We know that women experience adverse events at a higher rate, and these differences persist over the life course. But typically, clinical trials are not designed to consider these factors. Reports of adverse events following vaccination have shown gender differences. Early on, we had a higher percentage of women exhibiting anaphylaxis, and this was like an early signal. It since, I think, has equalized. It was more about maybe women getting more women being vaccinated initially. Now we have this signal in young male adolescents with myocarditis seeming to be more common among that group. And we don't know yet whether sex is a risk factor because the studies haven't been done. Closely related is the recommendation number 3, that pregnant women should be included in vaccine development trials. Pregnant women are more likely to develop severe COVID and need ICU, but still many countries are not recommending pregnant women to be vaccinated because the original clinical trials did not include, they in fact explicitly included pregnant women, and the development and reproductive toxicology animal studies were not done. This is now catching up, but still the evidence is only just beginning to emerge. The fourth recommendation is that the planning and implementation of vaccine delivery must be gender responsive, starting with the prioritization of target groups through to the timing and the location of vaccination services and the design of communication messages. Again, we don't have much data available, but across countries, there are gender differences in who is getting vaccinated. This is a slide showing COVID-19 vaccine coverage of at least 1 dose. And you can see in some places, more women, in some countries, more women are being vaccinated. That's at the top of this graphic, the purpley colored bars. And as you work your way down the graphic, the blue bars are the males, and you see that that's increasing. So in other countries towards the bottom, you're seeing more men are being vaccinated. And we need to understand the reasons behind this. Is it something to do with the way the program is being rolled out, or is it other factors? A gender responsive program design is critical, but this needs to be complicated by gender sensitive programmatic monitoring. We've already spoken about safety surveillance and the need for sex disaggregated safety surveillance, but just to highlight here that acceptability, hesitancy, and access are issues that are highly gendered, and information and indicators need to be in place to monitor these things as well. And there needs to be a continuous feedback loop between the analysis of this data and the ongoing refinement of the design of the program to ensure equitable access. I quickly show this slide because it's a rare example, and it shows a selection of South Asian countries and how the gender differences in how COVID-19 information was received. In Bangladesh and Pakistan, more men than women found that the information that they received about COVID-19 vaccination to be clear and helpful. But in other countries, we see this pattern was reversed, and it was the women who found that the information was clear and helpful, and less so the men. So this speaks to the need to tailor those communication messages. We can't assume that everyone receives the same information in the same way or is able to digest or interpret the information in the same way. The final recommendation is that there must be equal participation of women at all levels of COVID-19 vaccine decision-making. Women is an often cited statistic, but women are the majority of the health workforce globally, 70%, but they hold only 30% of the health leadership positions. So in summary, what I hope I've managed to convey to you in just this very short presentation is that we do need to apply an end-to-end gender lens to the COVID-19 vaccine effort, from research to development and delivery, if we really are going to achieve our goal of vaccinating everyone, everywhere. Thank you.
Thank you so much, Tracy. And we are totally recognizing that the time is very short to go in depth into the various recommendations, but it's very good to see that we have this forward-looking approach to coming up with specific ideas of how we can address these issues. And I'm sure we will have a lot of questions and opportunities for discussion, but for now, I would like to introduce our second speaker. So Lavanya Vijayansingham is a postdoctoral fellow at the UNU International Institute of Global Health, where she is responsible for the gender and health hub, and is also working on gender and health policy and research, and specifically on the COVID-19 pandemic. So Lavanya, the floor is yours.
Thank you very much, Shirin. And hello, everyone. Hope you're doing well and safe. And thank you once again for joining us today. I'm going to be talking about the guidance note and checklist for tackling gender-related barriers to equitable COVID-19 vaccine deployment. But before I get into that, I would like to acknowledge that this is the joint product of all of our partners. That's the SDG 3-GAP Gender Equality Working Group and the Gender and Health Hub at UNU-IIGH. My colleagues will be posting the link to the full document through the webinar for your reference. So this document outlines a set of conceptual approaches and practical actions for countries to consider. Reiterating a lot of what Tracy has described, the big ask is to address sex and gender amongst other broader equity considerations and focus on how these intersect with other health, demographic, or social categories to produce barriers to access and risk of harms, etc. So in an ideal world, this should be happening across the R&D continuum, its data evaluation processes, policy making, the planning and implementation of deployment strategies, and importantly, the communication to public. So the actions outlined in this document are categorized based on the domains already outlined in WHO and UNICEF's guidance to COVAX-supported countries as they develop and implement their national deployment vaccination plans. So here are some of the broad approaches we suggest. Now, this is a crucial time for us to learn from established knowledge on how sex and gender influences health and vaccine outcomes and seek some real-time emerging information on these aspects. A broad range of stakeholders should be consulted and collaborated with, and this includes women and community organizations and the non-traditional stakeholders or those who may not have worked together necessarily before. So these are some of the domains in the checklist. Now, for today's discussion, I'd like to focus on some of the domains relating specifically to vaccine data, evaluation, and communication. So in regulatory processes, we're advocating that sex disaggregated data on safety and efficacy outcomes is essential to support evaluation and decision-making for emergency use, approval, or authorizations. So rolling reviews of this evidence is possible, and we're calling for countries to consider negotiating a time frame of sorts for the delivery of this data and analysis, and perhaps imposing a penalty when it's not delivered on time or without sound justification. In the post-market process, we're restating the importance of not just collecting but reporting the age and sex disaggregated data. This is already included in the WHO Safety Surveillance Manual, and perhaps the point is to ensure the implementation of how we address any gaps in reporting. And so, of course, in the monitoring and evaluation, we need real-time sex and age disaggregated data on the coverage, the uptake, the completion of a dose schedule. All of these need to be collected, analyzed, and reported. So, of course, the communication of the science through targeted strategies can help build confidence, support uptake, and in turn, perhaps drive the evidence generation process itself. It's important to understand the nuances of people's concerns, the accessibility of the available information around these concerns, how information is accessed, and who is considered a trusted source among different subgroups of women, men, and gender diverse people. So this knowledge can then be used to craft targeted, evidence-based, and culturally sensitive messages that is then co-created with stakeholders who have gained the population's trust and using diverse communication channels that are popular with different groups to maximize outreach. So I'll stop here. And once again, I invite you to refer to the full document for more details. And let's please talk more about how we can implement these actions that we're proposing at local and national levels. And thank you so much for your time.
And thank you so much, Lavanya, for this really important checklist. And again, for keeping the time, we appreciate that. I know there are probably quite a few questions for both Lavanya and Tracy, but if I can just kindly ask you to put your questions in the Q&A box, and we'll make sure that we will come back to you after the panel discussion. So I would like to introduce Jean Munro, who will be moderating the panel and introduce our panelists. Jean is the Senior Manager of Gender Equality with Gavi, the Vaccine Alliance. Jean has over 20 years of experience working in the area of gender equality, inclusion, and women's rights across numerous sectors and in several different countries. So Jean, the floor is yours.
Corinne, thank you very much. It's an honor for me today to introduce a very unique and very knowledgeable group of panelists. First of all, I'd like you to meet Apurva Mandavili, who is a reporter with the New York Times, focusing on science and global health. She's the 2019 winner of the Victor Cohen Prize for Excellence in Medical Science Reporting. And she has the perfect education for our discussion today. She has both a master's in journalism as well as a master's in biochemistry. She co-founded The Cultural Dish, which is an organization dedicated to enhancing diversity in science journalism, and was the founding chair of the Diversity Committee for the National Association of Science Writers. Wonderful to have you with us today.
Thank you for having me.
Thank you, Apurva. We also have Dr. Noni MacDonald. Dr. MacDonald is a professor of pediatrics at Dalhousie University in Canada. She is the former Dean of Medicine at Dalhousie and was the first woman in Canada to be a Dean of Medicine. Her two current major areas of interest involve global health. The first is vaccines, including vaccine safety, hesitancy, demand, pain mitigation, education, and policy. The second area is micro-research, building capacity in community-focused research in developing countries and Canada to help interdisciplinary health professionals find local solutions to community health problems. Thank you very much for being with us today, Dr. MacDonald.
Delighted to be here, Jean.
And finally, we have Professor Saad Omer, who is the director of the Yale Institute for Global Health. Dr. Omer's research portfolio includes epidemiology of respiratory viruses, such as influenza, RSV, and most recently, COVID-19. He's conducted many clinical trials to estimate efficacy of maternal and infant influenza, pertussis, polio, measles, and pneumococcal vaccines. And he's conducted trials to evaluate drug regimens to reduce mother-to-child transmission in HIV. Moreover, he has conducted several studies on interventions to increase immunization coverage and acceptance. We're looking very much forward to hearing you from today, Dr. Omer. So Apurva, I'd like to start with you. As a journalist who's been covering global health issues for many years, you have a good sense of the ebbs and flows of citizens' concerns. In your opinion and experience, has this pandemic changed people's attention on efficacy and safety of medical interventions?
Thank you for that question. And the answer is actually an absolute yes. I think we've noticed actually that people are more interested in science in general and in health in general because of this pandemic. There's just been an enormous amount of attention on really things that I didn't think any general reader would ever care about. This isn't really about gender, but I wrote a piece about cycle threshold values for PCRs, and this is not something I thought we would ever see in the pages of the New York Times, but believe it or not, that was a very well-read article. So I just use that as an example to say that this is a very unusual public health scenario that we've had, where people have been intensely interested in the research that's going on, in the results that are coming out, including how they are disaggregated by sex. And that's, definitely a new thing. From the very start of the pandemic, as Tracy mentioned, we saw these sex-related statistics on who is affected, who gets severely ill, who dies. And there was a lot of interest from the beginning on that. And I think that highlighted to people that there are differences between men and women in these diseases. And that's not that people didn't know that before, but I think there's never been this sort of focus on that issue. You mentioned that I've written about global health a lot, and one thing I've written a ton about is HIV. And HIV is, it's been around forever, and yet people don't really, I think, realize that it affects men and women differently, and that also a lot of HIV research, even though about half the people affected are women, HIV trials have very, very few women in them. There's something like 10% of cure trials, the participants are women. And vaccines do a little bit better. The HIV vaccine studies have been closer to 35, 40%, but that's still not half. And there hasn't been the same sort of attention or outrage about that as I think there could have been and should have been. But from my perspective as a journalist, it seems like the attention that's being given this time around could actually have long-term implications for global health and how research is done in these areas. This time there's so much more attention on the side effects and how were the vaccines tested. And obviously people have always been worried about the flu vaccine. Pregnant women have always had worries about that. But this time there's been an attention on why weren't pregnant women included from the start? Why weren't the DART studies done, the toxicity studies done right from the start? Why weren't they being collected as the trials began? What's the effect of the vaccines on fertility, and on treatment? In the early days, I was hearing a lot from women about telehealth and what is the research available that if women skip some appointments and just do their prenatal appointments by telehealth, for example, how much will it affect their fetus? And also just even all the way through birth and delivery, women being separated from their partners, women being separated from their babies at birth. There was a lot of interest and questions being asked about what do we know about this? Has this ever been studied? Do people even know if this is a good or a bad thing? And I think that really drew attention to the fact that we as a society have not really prioritized research on women and have not included women in research. And the pregnant, the exclusion of pregnant women from clinical trials is such a long and ongoing issue. And I have not seen the conversation around it be this clear-headed and sharp as it was in the last few months. And again, that's a topic that I've always been interested in very intensely. And so I'm curious whether we move on from this and start to really include women in clinical trials, or we go back to normal as soon as the pandemic has shifted from people's minds.
It's a great question, what the future looks like. But maybe to help us get there, I would really like to hear your opinion on why have women continually been excluded from these trials? Why haven't we had maybe the full communication about the results? And then because you're very close to citizens, understanding what their needs and wants are, what are citizens' needs in terms of going forward and the type of clinical trials they want in order to feel confident with vaccines?
Yeah, I mean, the why question is perennial as well. I think a lot of women actually don't know that they can be involved in research, or if they do know and want to be, they just don't have the access. I mean, they can't get there because they're too busy taking care of their kids, or they have job commitments. They have lack of access to transportation in many parts of the world. They don't have autonomy. They don't have independence. They don't have the ability to get themselves to these places. And in other areas of research, I've seen that things really only change when there's a very concerted effort made to focus on including women in the research, and on, the clinical trial researchers or, other researchers go out into the communities and talk to women. And I think that has not happened as much in this pandemic. At least it certainly didn't at the beginning. And partly, of course, that's because there was just a lot of chaos at the beginning. And I don't think anybody was really paying attention to what was being done. And the clinical trials were starting so quickly. And as Tracy mentioned, there were a lot of calls to include women, but I don't think anybody was holding their feet to the fire and saying, you must include them. I think one area in which that did happen, and it's a good example for women's groups to learn from, is how the HIV activists, again, they are so good at advocating for themselves. And I think, at the beginning, the vaccine trials did not include HIV positive people until the advocacy groups came together, argued for it, and demanded it. And then Moderna had to sort of change their protocol and include them. And I think that's the sort of thing that needs to happen to include women. And there's, as I mentioned, a lot of hunger for this information. I want to read you an email I got yesterday. A woman who is pregnant and is nervous about getting the vaccine wrote to me and said, for some of us, not getting the vaccine is not an act of defiance. In fact, I plan to do it after my baby arrives. But with data only dating back to December 2020, there's not enough research on the long-term effects a vaccine could have on unborn babies to make me feel comfortable with it. And I think that's the key. There's not enough data to make me feel comfortable with it. And I actually wrote her back and directed her to some of the data from the clinical trials and pointed out it's not just December 2020. There were pregnant women in the trial, women who happened to become pregnant. There is more data than that. And she was more reassured and said she would look at the studies. But I think that's an indication of how little communication there's been to women about what their risks actually are, what's being done to collect that information, when will that be available, how should they think about it, who should they talk to, when should they talk about it with their doctors. There's just a complete lack of information at every step of the pipeline. And clinical trials didn't really present data disaggregated by sex and gender. Some did, but a lot didn't. And as the vaccines came out and we saw these effects on, by sex of the J&J vaccine and the AstraZeneca vaccine, and more recently myocarditis with the Pfizer and Moderna vaccines, people are aware that there is a difference, but they're not aware of exactly how they can protect themselves. And I think that's been a really big problem throughout this pandemic.
Thank you. Thank you, Apurva. I think this leads in well to our question to you, Dr. Omer. So you've led many studies and evaluations of efficacy of various vaccines. So in your experience, how well do you think sex and gender variables are used in vaccine outcome evaluations?
So generally, there's been a mixed record. And that has reflected into the clinical trial portfolio and other sort of post-marketing evaluations of this pandemic as well. When it comes to phase 3 trials, the ones that were done, some of the vaccines, the mRNA vaccines and the AstraZeneca vaccines, have either, at least in terms of male-female representation. So I think for the Pfizer-BioNTech phase 3 trial, it was 50.1 sort of men versus 49.9 women. I think AstraZeneca was 60% women, and so on and so forth. But here's the thing, a lot of the world is not just using these vaccines. So the vaccines like Sinovac, Coronavac, the Gamaleya vaccines, it has been a mixed record. And a lot of times it's not just reported because the trial reports, a lot of the communication is happening through press release. And we haven't had a lot of peer-reviewed publications for things that are actually being deployed. And so that's even for phase 3. We have done worse in terms of post-marketing studies, especially of effectiveness, but also of safety. And in the context of COVID-19, there's been a really patchy record. And there are, so to paraphrase someone, that it is, there are a lot of unknown unknowns because the data are not reported. Often we, and sort of, I was engaged with the GACS manual, the Global Advisory Committee for Vaccine Safety manual that I think Tracy showed, and there was an emphasis on sort of collecting these variables. It's not that the tools are not available, and hopefully we'll come back to, you know, why some of this is happening. And one of the reasons, and I'll briefly touch upon that, is that often you get pushback when you try to do that. So throughout the pandemic, my research group has been collaborating with my immunology colleague at one of my immunology colleagues here at Yale, Akiko Iwasaki, and we did one of our earliest studies of vaccine or actually immune responses to infection in one of our cohorts. We received pushback when we did it by biological sex, and then sort of then looked at it as a sensitivity analysis with gender as well. And we got pushback on actually doing that because, and I think we continue to believe it was a legitimate question to ask because the epidemiological data were there. But then there is another aspect, and I'll give you a couple of examples. Even there was an interesting analysis of who was leading the phase 3 trials who was leading COVID-19 studies, including trials, and who was the PI. That includes vaccine and non-vaccine trials, and only 27% or 29% were women. Which is, and they did a nice comparison with breast cancer intervention-related trials, which is, I think, a little above 50%. So it doesn't have to be this way. Both Dr. McDonald and I know, and I hope you'll agree that it's not a deep bench issue. The bench is deep enough. There are more than enough qualified people of both, or actually of many genders that are capable of leading these trials. And the reason I'm bringing it up is that even before the pandemic, for the sort of last for over a decade or for 15 years, I've been engaged in maternal immunization related work. And there was, we received a lot of pushback going back, and it was alluded to that why we don't have pregnancy studies, et cetera. So some of these structural things matter, like who's at the table or not. We have been doing both trials, and some of them were used as for priority setting in the H1N1 vaccination during the H1N1 pandemic to prioritize pregnant women as a high priority group. And then we've looked at acceptance studies. And we were finding this we were finding this consistent pattern that women were not just prioritizing themselves, but their offspring as well in that kind of, both risk benefit, et cetera. It wasn't separate. But then there was effort, and there was some fairly influential paper that came out in a prominent journal, unfortunately with a few very well-meaning WHO authors representing their own perspectives, which is always the case, that came out and said that maternal vaccines should only be used when it benefits both the mother and the neonate. So this is very important. And so I happened to be in Atlanta at that time, and one of my mentees happened to be pregnant at that time. And we said that really doesn't make sense based on what we are finding when we talk to women themselves, when we collect data, women say that we want to prioritize the neonate. And they're not just passive recipients of this seemingly sort of beneficent paternalism. And we said, wasn't there a woman in the group who raised her hand to say that it really doesn't, the framework doesn't make sense? It turns out there wasn't. And so then we came out with a framework in science in terms of how to do these studies. And, and obviously we were a much more diverse group of people. And we included it in that framework that women should be at the table. And it's not just a sort of a bureaucratic a fairness-based argument because women academics and researchers should get equal opportunities. It matters how naive or otherwise the policies are, and how closely they reflect the data that is out there. And so the reason I'm bringing it out as an example is that there's a lot of these attitudes that are ingrained that often sort of originate from a perspective of self-righteousness, but they manifest as seemingly beneficent, the knight in shining armor syndrome that is often part of the global health discourse. And so I'll pause here, and I'm sure you have follow-up questions.
I would love to see the article entitled "The Knight in Shining Armor in Global Health." I think there's a lot to capture there. Thank you for that. Dr. McDonald, I'll pass over to you now. So you're a renowned researcher in vaccine safety and hesitancy. So building on our past panelists, could you share any examples you have about how well sex and gender, so looking at both the biological side as well as our cultural and social norms, how well that's featured in vaccine research, data evaluation, policy decision-making, and our public communication? Over to you.
Thanks, Jean. Sada's given a great background to spring from. So I want to present two examples, bad examples of where we didn't do a good job. So if you look at the Ebola outbreak that we had in DRC several years ago, and the Ebola vaccine was still in development, but we'd had good phase 1, phase 2, and phase 3 trials, but we didn't have enough to go through the regulators to be fully approved and out there. And so after much toing and froing at SAGE, at WHO, it was agreed that we should go forward and we would collect data. When it was being rolled out, that each person who got the vaccine would be part of the study and go forward. But when it came to us saying, well, what are you going to do about pregnant women? There was, whoa, can't have pregnant women doing this because we don't know enough to be able to do it. And this is the overabundance, I'm going to give it another name than Saad did. This is the precautionary principle gone berserk. Okay, because if you look at the mortality rate of Ebola among pregnant women, it's 80%. And I know of no vaccine that would ever even make it through phase 1 of a clinical trial. If it killed 8 out of 10 people in the phase 1, it would never even get anywhere near where these vaccines have gotten. And yet we precluded healthcare workers who were women, the majority of healthcare workers, from even being eligible to be in this. And for me, I couldn't believe that this discussion was even taking place. It was like the logic got lost. And when you talk to regulators, there's a firmness about this precautionary principle that I think is the wrong end of the telescope. I agree, we shouldn't leap forward for drugs and stuff like that when we don't have a lot of data and we need to be sure there's no harm. And that's why we do phase 1, 2, 3 trials, okay? But when we are in a situation where literally people are dying like these pregnant women were, and the babies died too. So it's a 2 for death. It's not a 1 death, it's a 2 deaths. And yet we wouldn't even offer it to them when we had no evidence that there would be any mortality with this particular type of vaccine that it was. So I think there is a culture out there that has not really looked at some of these women's issues in the way they need to be looked at. What is the long-term outcome of the decision you're making? And then going back to what Apurva said, when you start with a very kind of negative thing about having these vaccines in pregnancy, WHO did that, CDC did that, many of the high-income countries' regulatory authorities made this a very cautious thing. No, well, you can sort of consider giving the COVID vaccines if the mother weighs up the risks and benefits and blah, 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 make it really hard. All right. Well, then when you change after you've got the safety data and after you've got the effectiveness data, for the women to hear it the other way around, it's very hard to change and say, which of these is correct? All right. And so we started with a very negative consequences. The other piece that I want to say, coming along a little bit from what Tracy said, if we look at the COVID vaccine trial data, yes, as Saad said, a number of these trials had pretty equal men and women in them. But you know what? When you look at the data that they published, the data is not broken out by gender in terms of efficacy, in terms of immune response. So they'll just give you the neutralizing antibodies, but they don't tell you if the women were different than the men, nor did they tell you if this changed over age. They do tell you over age, but not done by gender. And I think this is being disrespectful of both genders, okay? In that we really need to know how this is affected over time. And you'd think in 2021, we would have got there, because we know this is so important. Immune responses are not the same in adult women as they are in men, and immune responses don't stay the age in women. So, and we do know, it was kind of hilarious to me, they did split out the common adverse events that happen in the trials that you would see, headache, fatigue, and so on. They did split those out by gender, a number of them. Well, because they happen to be more in women, and we wanted the men to feel safe. That's my take on that. And I may be wrong, but I do think it needs to be looked at, and we should not be disrespectful in the way that we're being. Last point that I wanted to raise on the question and related to this was, do I think we could do this differently? Well, if I look at what we have done for children who, when I started as a pediatrician in the 1980s, you need to know globally, 80% of the drugs we used in children, 80% of the drugs we used, we had no clinical trial data for use in children. All right. They were just ignored. You just take an adult and scale it down and give it to the kid. And we learned bitterly that this was not a good thing to do. And so what happened was there rose up a demand that said not good enough. And that led to a number of the regulatory authorities changing so that when a drug is now brought forward to be approved by a regulator, if you don't have children's data and it's going to be used in children, they go, yeah, bad. And if you do have the children's data, they expand your approval and will give you longer time under patent. So there are ways out of this if the demand and the critical thinking out there pushes hard enough on a broad enough group. So I don't think it's hopeless, but I do think we can do better. We really can do better.
Thank you very much. Those were great examples, and I mean, you do have this experience that we can really learn from. Saad, I'll go back to you. Building on Nani's point there, and you ended on this as well, kind of about the frameworks. What kind of changes do we need in the frameworks? What challenges do you think we're going to experience as we go about making these changes, based on your experience already running these trials and working with regulatory boards? What challenges do you foresee?
So one of them is this, again, I think I love Noni's formulation as well, that the overzealous implementation of the precautionary principle, which is sort of differential by gender. So having been in a lot of places by other, in terms of formulating policy, drafting guidelines, often the pushback is harder on things that are relevant to women and other gender minorities. Obviously, that's a different conversation. Actually, it is very much part of this conversation, but that's an additional dimension to this. But you get you're asked to provide a higher burden of evidence in this. And I think part of it is, and at least that's what we framed and proposed as both of a part of the diagnosis and the solution in the framework the ethical framework we proposed in our science paper a few years ago, which is to say that to recognize the centrality of women's agency. We do not, so sometimes we talk about autonomy, but we teased out the separate concept that women are not passive recipient of recommendations made by well-meaning people, and often, in a lot of cases, empirically, men who are trying to do the quote unquote the right thing. They have agency at various levels, and that should be reflected in who formulates the policy, how the policy framework is developed. And there have been a few reports. There was a report that I was involved with the National Vaccine Advisory Committee on research in trials in pregnant women for vaccines that actually try to address that a little bit, and provide structural incentives that moves away from this overzealous implementation of precautionary principles. So both legislative and regulatory fixes that incentivize these kinds of things, recognizing the centrality of women's own agency. And this is not just true for pregnancy trials, etc. I would also go back to another group that has been missing from the discourse, and that has been sort of hinted at, or actually included as an example of a socially vulnerable group, is those who with diverse gender identities, and also sort of other groups that come in within the LGBTQ plus populations, because these groups have differential access to care and trials, and that is a big black box, especially in LMIC trials, but also in post-marketing studies and monitoring access to vaccines. So that's another huge data gap, and that builds on the underlying structural inequities that these groups face.
Yeah, thank you, Sad, for raising that. Certainly when we are talking about gender, we do mean the whole LGBTIQ plus communities. And we've seen, and you've just restated that they've been absent, both from policy making as well as the vaccine trials and the leadership of vaccine trials. Apoorva, I'd like to move to you now. So again, going more towards communities' vaccine confidence, I'm wondering, how can media and public opinion play a role in facilitating the implementation of the recommendations that Said has spoken about, and the overall stronger science focus on sex and gender aspects across all medical product research and development?
Well, I can talk most about what media can do, so let me do that.
Perfect.
I think the key for media is to really cover the fact that there is a lack of data, and data disaggregated by sex and gender, and to balance the risks and benefits when we talk about it. I think often, people in the media talk about the evidence because that's what's being thrown at us, and it's harder sometimes to see what has not been done and where the evidence is lacking. So I've tried to write a lot during this pandemic, for example, about the differences in immune responses in men versus women by age, because as Noni mentioned, it does change by age. And, for example, older men seem to have the worst response per research from Yale University, from Akiko Iwasaki's lab. And this is something that most scientists know, but judging from the responses to the articles I've written, I don't think the average person is really aware of how much things differ by sex and gender. And so that's really, I think, important for articles to get into. And instead of, just saying that there is no evidence, really addressing it head on and asking, why not? Why isn't there this evidence? My colleague, Alicia Hardasani Gupta, who's a gender reporter at the New York Times, wrote in April, calling out, for example, that the initial coronavirus task force of 12 people was entirely male. So when that's the case, you can see why the decisions get made the way they do. And it's important for journalists to really call attention to that. The other thing that I think it's important to do is in a lot of these conversations, when we talk about clinical trials and who is included and who is not, people lump pregnant and lactating women together. And I think it's really important for scientists when they talk about it to not do that, and also for journalists to separate those out and talk about what the risks are to each group. It's because it's hugely different, and often the risks to lactating women are almost nothing, and if there are for pregnant women, that needs to be put into context. So I think all that kind of context setting is really important. And people, take it for granted that pregnant women should not be involved. That's just sort of the status quo. So I think it's on journalists really responsibility to question that paternalistic standard, just like we question everything else, about why pregnant women aren't included, and is that really what's best for them? And as Noni pointed out, this is not always, the risk benefit doesn't always work out in favor of excluding women, and most of the time it doesn't. And so that's, I think, really important to highlight to readers who come from this traditional place of, well, of course we don't know the risk, so they shouldn't be included, and that's a sort of immediate response. So I think it's important to bring in other perspectives, and one way I've tried to do that is by quoting bioethicists like Anne Lyerly, when talking about these issues, who can point out why it's important to include pregnant women, why it's problematic that they're not, and what's being done to change the status quo, because there is a lot of movement on this front. There's, the new panels out of the UNU-IIGH, there's a lot of conversation, and there seemed to be some momentum, at least before the pandemic, and hopefully the pandemic will help that and not block that, but it seems too early to really say. So I think that I'm really interested in following what changes because of this pandemic. And I think it's, I hope my colleagues at other publications do as well. And one other thing that has been very important to do throughout this pandemic is to hold public health agencies to account. We've had to do that on many, many fronts, because as you all know, the CDC was hugely politically controlled, and all the documentation coming out of it was often doctored. But it was also true of the WHO to some extent, not directly politically influenced, but really sort of pressured, I think, by public health expectations from governments and by funders, and also sort of a reluctance to be too controversial or sharp. I think the WHO is very conservative, and sometimes it's important to call that out. So, in this case, the advice to pregnant women about vaccines was a really good example of that. Noni mentioned that briefly. The CDC, the advisory committee said the pregnant women should consult with their doctors, and that's, at least it's a step, because they're not saying don't do it. At least go talk to your doctors, and it puts the agency in the women's hands, which is mostly good, although they could have been a lot clearer about what the risks and benefits are. But the WHO, based on the very same evidence, recommended that pregnant women not receive the vaccine unless they were at a high risk for COVID because of work exposures or medical conditions that they have. And that way that was worded was so forbidding, and it's also really confusing for women to have one of the leading public health agencies say, yeah, it's okay, just make sure you talk to your doctor, which is basically how that came across from the CDC. And the other major public health agencies say, no, don't do it unless you absolutely have to. And I think that's incredibly important for journalists to call out. And I did that. And of course, I got a lot of pushback from the WHO and other places, but I think it's important to say that very clearly, that this is confusing and you are doing a disservice to women to put this decision on them and their doctors, instead of providing very clear data-based guidance and not assuming that the lack of evidence means that there is evidence of harm. Sometimes that phrasing, the messaging gets very muddled. And that's where I think journalists can be very helpful. And the last thing I'll say is that because of this story, there has been a lot of attention to other issues in women's health as well. One story I wrote recently was about, after the J&J vaccine risks about clots came out, a lot of people were making comparisons to the risks to women from birth control and saying, well, that's a lot higher. And, we don't stop using birth control. And I think their point was, don't worry, because you've been taking birth control and that's been fine. But what it did for a lot of women is say, wait a second, that is true. we do take these birth control pills and they have like, 1 in 1,000 risk. Why are we still taking that? Why aren't there better birth control options? And it sort of revived that question. And I think that's also really interesting to do, is to lean into where the lack of evidence has been sort of swept under the rug and just assumed to be the status quo, and say, this doesn't need to be this way. What's being done to change it? And that's a lot of, I think we'll see the fallout on other aspects of medical research from that for a while after this pandemic.
Thank you, Apurva. Yeah, you've certainly got people talking, certainly in my circles, the whole discussion about why there are such a high risk of blood clots in the birth control has, got people talking and thinking and questioning, and you play a really important role in getting us thinking differently. Nani, maybe you can build on some of these recommendations that Apurva has said about moving forward. What are some of the key things that we need to think about and consider? We're in shifting sands. So if we're going in the right direction, what can we do to support that movement?
I think there's a whole bunch of things. Having done advocacy for my entire career, there are things we really know that work and that make a difference. First of all, I think Apurva said, we've got to make the topic have gravitas. All right. We need the evidence out there. We need the gap shown, and we need that widely shared, not just among a few people in academia or a few people in a few organizations. It needs to be out there that the general public's talking about it. So let me flip back. When I was at university, and I can well remember this, we actually had a conversation, which blows my mind, whether women should be paid the same for the same job. Because my mother had just been appointed a principal of an elementary school, and she was the first woman to be a principal of an elementary school. And should she be paid the same amount? Because she had a husband, so she didn't need the money in the same way. And now nobody would be having that discussion. Okay, so we can change things when we put a spotlight on it and show why it's just wrong. So it's got to have gravitas. It needs to have many touch points. We can't just make this is about women, because then we'll get swept in the closet. This is about women, and this is about men, because not doing this kind of analysis is harmful for them too. So it has to be broadly owned. And then we need to, I think, get beyond the usual partners that talk about this. So we have to show the economic impact of not doing vaccine by gender correctly, because if we don't do this right, it costs our economy, because women or men, depending on where the gender issues were, are not going to be there or be as safe as they should be, or be able to work in the way they should. We can't control the epidemic as well as we could, or as fast as we could. So I think we need to get the World Bank even louder onto this. We need to be looking at the whole economy piece. We know that of the Sustainable Development Goals, this has well been said by Gavi, immunization affects 14 of those 17 goals. Okay, well, we've got to get the immunization thing right, folks. I mean, this has a huge impact. And I mean, COVID, if there's one thing it's taught people, vaccine preventable disease like COVID can just wham you, totally change your whole life, change everybody's life. And gender has a big piece in how we're going to get that controlled, because we have to understand your immune response. We have to understand how to make access equal. We have to understand how to get everybody immunized. So, and then the other piece is we need to have the advocacy strategy really being written out large, so that the World Health Assembly starts talking about gender and immunization and why this is a big issue. We have to get the regulatory authorities to get up and active on this, just like they did for the children's issues, to say, no, when you bring us data, you have to show us gender across the whole thing, not just that you have equigender in your trials, but that you've actually analyzed the data by gender, by age. All right, because we need to know this. And we need to grow demand that pushes on those systems so that they won't. I think there's also some issues. There are some legal barriers sometimes for this all to be done. And, you know, a company's not going to stand up and do pregnant women research if they think they're going to be slapped with teratogenicity stuff and concerns about their products. So I think we need to be talking about the liability issues if we want the pregnant women data to come out more quickly. And we need to solve that. And Prevent came a lot forward about how this needs to be done, but the regulator has to demand that that data is there early, not late. And last thing, we need to benchmark, all right? Because if we don't count something and we don't follow along how that changes, it doesn't count. And so we need to be seeing what's actually happening and reporting regularly back to say, we don't know this. Well, come on, guys, get better. And just like for the joint reporting forum on how UNICEF and WHO requires every country. And look, 194 of those 194 countries report annually on a whole lot of factors on immunization. Why can we not have the same kind of reporting back on clinical trials for vaccines and on data about women for vaccines? Why can't we demand this? I mean, why can't we make the manufacturers do this? Now, that reporting for the JRF, it's voluntary. Nobody comes back and holds a gun to the head of the country and says you didn't report, but you would be embarrassed not to report because they call you out and say, we didn't have data from so-and-so and so-and-so and so-and-so. Well, we could do the same thing on the trials data if we pushed, but if you don't count it, it doesn't count for this particular type of topic.
Indeed, indeed. I think those are all great recommendations. There's a number of questions I see in the Q&A, so we would like to move to Q&A now. Lavanya, I'm just checking, are people able to raise their hands? Yes, okay. So for the audience, could I ask anybody who would like to raise their hand, please do so now. And for our panelists, if you could actually go into the Q&A, and you'll see there's a number of questions that are directed directly to you. If you can answer in the chat, in the Q&A area, that'd be great. For anybody else, if you'd like to raise your hand and pose a question to one of our panelists, please do so now.
Sorry, Jean, the participants are not able to raise their hands. But
Okay.
if you would like to call someone from the list, we can.
Okay. From the Q&A list. Is that right? Okay. Great.
Jean,
Yes.
we have and Jeanette, who will provide an intervention for us, a little bit of a comment in response to the panel as well.
Okay, thank you. Sorry, could you say the name again?
Kara and Jeanette.
Okay, Kara, could I ask you for your comment or intervention? Thank you.
Hi, with pleasure. My name is Kara Tannenbaum, and this has been a really interesting panel. Thank you so much to everyone for your recommendations and for the hard work. I think my question is that the world today seems to think that sex disaggregated data on drug, safety and efficacy is a nice to have, not a need to have. And I'm reminded that the International Council on Harmonization doesn't actually have a specific guidance paper for women, making the decision almost 15 years ago that it wasn't necessary. My question to the panelists is, what can we do urgently to make it mandatory for regulators and industry to submit this data disaggregated? And what can we do? Because if the International Council on Harmonization tells everyone that they have to do it, then it'll get done. So why is it taking so long, and what's your advice? Thank you.
Which of the panelists would like to take that?
Jean, can I just start on that one? That was my point about we need to widely give the topic gravitas, why it matters, because clearly they don't see that it matters. And because vaccines the whole way they work is generated through your immune response. And we know that that immune response is not the same in adult men as it is in adult women. It's like, duh. Okay, so that's why we need it to be done, but we need people to understand that. And then that's what I meant by gathering people together to demand that this happens, because it's good for both men's health and for women's health to know this data. And as we're moving for immunization across the life course, we're going to have more and more vaccines that will be given in adults, and we need this data badly.
If I may add to that a little bit, yeah. So I think on the same track as what Noni mentioned. So as someone who's done behavioral intervention trials, I can tell you, cultural change. It's often the structure has to change before the culture changes. So I recognize the limitations of this, culture change, which is important. But often we have to have cultural incentives and structural incentives and structural penalties, as was alluded to. So here's what, again, my suggestion would be specifically. So now there's a critical mass of data discussion. I think Lavanya was the first author on the Lancet paper that came out, and the reports that are there, that there is enough tools to advocate for it. Let's advocate vociferously, unapologetically, to put in structural incentives to do this, because the case for it is fairly strong, both from the scientific perspective, but also from the social perspective. So legislation, regulation, and holding people accountable, both through sort of academic reports, but also journalistic sort of interventions. And there's more than one occasions when sort of holding the policy makers' feet to fire has helped nudging things in the right direction. So these are the 3-4 specific things that I submit can be done.
Great, thank you very much to both. I'd like to turn to a question from Jeanette Wolf.
Hi there. Can you hear me?
We hear you fine.
My name is Jeanette Wolf. I'm a professor of emergency medicine at UMass Medical School Bay State, and my area of deep focus is sex and gender-based medicine, and I was one of the authors on that Lancet paper with Lavanya. I have a comment and a question. My comment is, as somebody who's spent the last portion of her career really trying to engage medical colleagues in investing in sex disaggregation and including biological sex and gender in their own bodies of work, I have found it challenging because oftentimes it's very hard to distinguish what is a biological sex difference versus what is a gender difference. And I think that most of my colleagues could say, objectively, if this is a physiological difference, I am on board. But once it floats into the less defined gender differences, it gets a little bit more tricky and it gets a little bit bigger and people get more paternalistic, more defensive. So that I have found has been a specific challenge. And one of the things that I've realized when trying to convince and engage colleagues, it's not just the data, it's the perception around the data. So that's my comment. My question is, as somebody who's been very involved in academia and has tried to go over, not just for myself, but to bring other academic writers into the popular press, it has been challenging to do so. And some of the feedback we have gotten, because some of these variables are not easily distinguishable, when we start talking about physiological, biological sex variables, many of the editors are afraid of the pushback that we are not including non-binary gender variables. So comments as to how you think we could be more successful in expanding our platforms would be really helpful.
Yeah, that's fascinating, and does get a little bit to why are we not seeing this? As you're all writers and you're writers around research, I'd love to hear from any of you. Who would like to take the question?
I'm going to start a little bit, Jeanette. You've raised hugely important issues. And sometimes it's the words, they're loaded and they carry such a back piece to them that when people hear them, they immediately lock down into one particular view. I've written stuff on words that are really a problem in the immunization area. You know, I hate to tell you, but most people don't want to be called old. I'm old. They don't want to be called old or labeled old. They don't want to be labeled marginalized or vulnerable. All right. They don't want to be labeled something different. Okay. And so as soon as you stick the words in gender, okay, a lot of people go, ugh, all right. And because they don't see it as just, they see it as not necessarily coming from the biological point of view, but also from cultural. And so I think it behooves all of us who do writing in this area to be, I'm putting this in quotation marks, a bit subversive and a bit tactful, and finding words that can slide through so you can still get the message out there without people backing off from the very beginning. Because the other problem when articles are written like that, like I would probably say, Lavanya, I wish more people had read that paper, but probably didn't as soon as they saw the title, okay? Because I don't need to know that. It's not my field. And so I think we need to be much more creative in how we're framing this whole thing. And I would love it to be framed, this is about men's health, okay? Because it is, okay? It's about all of our health. It's about everybody's health. And so if we could make it owned, not as a women's issue, but as everybody's issue, then I think we'll get us much farther. Apurva, do you want to talk about that? Because I know as a journalist, you know how wicked the words are.
Yeah, I was going to say actually that I disagree with you a little bit on that, because I think social media has really changed things a lot. And there are so many women on Facebook who get information from Facebook, who make all the decisions for their families. And my experience actually with writing about some of this has been that there is a lot of demand for women to know all this information, what they can do, what they should do, what they should demand from their healthcare providers. And I think especially the younger women are incredibly energized to take charge of their own health and to demand the best and to demand equal treatment. And so I've found it really interesting to write about some of these things, because I think that the younger generation, and I don't even include myself in that, I think I'm talking about like 35 and under here, they're really interested in challenging the status quo. And I think it's good to be able to give them that information. And I've actually tried to say more directly, this is about women. And those articles have done very well. So I think
those are equal pay for equal work, like it was 40 years ago, 50 years ago. And I think that is well done. But I think the piece here is we've got, and I'm going to be very blunt, we've got old men in many powerful positions that we have to change. And that argument will change as the younger people grow up. But what do we do about the now? I want it in my lifetime.
I think shame is a very big motivator, even for older white men. So as a journalist, that's kind of where I look to make an impact, is how can I get things to change? How can I shine light on this? How can I bring the truth forward? And often when you embarrass the patriarchy, things change just because they don't want to look bad, not so much maybe because they really change and see the need for more research or for different policies, but simply because they don't want to be called out. So whatever works.
So we've heard two different approaches to how to make the change. Saeed was saying more, really getting regulators to change. You're talking about the more informal way of creating public opinion and
public demand.
Public demand, exactly. All really important. But I think talking about sex and gender, in a binary fashion is just not useful anymore. It might get us in the papers, but I don't think people will take it well, right? It's a messy way to write. And I would challenge all of our listeners maybe to share any really good writing that has taken all the fluidity of gender into account in science writing. I think that would be really good to see positive examples around that.
It's disrespectful, as you're saying, Jean, to do it that way. It's very disrespectful to make it binary.
To make it binary. No, yeah, it's just not the reality.
I think one area where that's been better is in HIV research, where a lot of the trials do demarcate transgender women and cisgender women. And so the coverage also has had to be equally sensitive and inclusive and talk about gender across the spectrum.
And it's not just, it's not just the biological aspect, right? It's the, when we're talking about the HIV or any of these diseases, it's about access and understanding around the diseases and how that changes across gender. I'm just looking at our Q&A. Saeed, there was one question from Asha about if you could get into more detail about what you were talking about, incentives and penalties for regulators.
So yeah, that was the question I was trying to address as well earlier on. So just to again summarize again, sunlight, accountability, both on the academic side and from the journalistic side, advocating for actual structural changes, both in legislation and regulation. And sometimes these changes include incentives in terms of rebates for including certain kinds of data, but also not accepting trial applications that don't have a plan for disaggregating data, not just on safety, but also on efficacy and effectiveness as well. So that's the point, with the assumption, with a somewhat cynical attitude towards that sometimes the structure changes the culture rather than the other way around. In reality, it's a cycle. But I do think we are at that threshold that there is enough momentum to not have a majority asking for it, but enough a critical mass that can advocate for it and hopefully find some allies to do so. So that would be my proposal.
Thank you. And we have a question from Rebecca for Nani or other panelists. Given that there's a lot of rumors around COVID-19 vaccine that leads to infertility, has a big impact on vaccine confidence. Are there any suggestions of how to address those rumors? Thank you.
So I'm going to come back at this the obverse way. There's been a lot of rumors out there around adverse reactions for COVID beyond the ones that we know are real. And one of them has been about infertility. And the part I find amazing about this is if you go back to find out where all of these come from originally, it came from the Depo-Provera time when in some low-income countries, women were given Depo-Provera the same way as you would give a vaccine to them. And they thought it was the vaccine that they were getting when they were actually getting Depo-Provera for family planning. And that got mushed together that vaccines could do this to you when there aren't vaccines that cause infertility. It just got attached. And there's a nice paper in 2015, and I apologize because I can't remember his name, is Gabaranski, I think it is, where he talks about how these myths come up over time. And that was written in 2015, but if you look at it now through the COVID eyes, you can see where each one of these has morphed itself into being attached to COVID as well. So infertility, you have to think about infertility. To be infertile, you have to do something to the sperm, and you have to do something to the egg, and you have to do something to where the sperm and the egg are going to get together and grow. Okay, that's not what any of these vaccines do. All right, it isn't what the problem is, but that's what it got attached to. I don't know, Sad, if you want to add more to that, and I'll quickly go and find out the name of the guys paper so I can put it into the chat.
Yeah, I'll just basically expand a little bit more. I think the underlying sort of framework is on target, but to a broader questions of these kinds of rumors, etc. So we often, as a community, demand high level of evidence of efficacy and safety interventions or systems, but we accept a lot of fluff in disinformation management, vaccine acceptance interventions, etc. So for a lot of these things, infertility and or sort of interference with reproductive function, we have experience with HPV, and they have been sort of interventions that have been developed, evaluated narrowly and broadly to address some of this kind of stuff. And there are resources out there now that synthesize that evidence. So part of it, and this is not just limited to gender, is to demand the same quality of rigor in terms of the tools that are enhance vaccine acceptance or address disinformation or misinformation as we do for vaccine development science and vaccine safety science.
That's a very good point. Lavanya or Tracy, did you want to come in on any of these points or to respond to any of the questions that are in the Q&A? Lavanya, did you want to respond about response to the myths around infertility?
I can just add that, yes, it's a recurrent question that is coming up even from our regional offices. We did respond and some good resources have been put. We look forward to getting Noni's reference as well, but some things have been added. It is unfortunately something that we've encountered with other vaccines, the tetanus toxoid vaccine in particular, when it targets a group of reproductive age women and is not necessarily gender balanced because the vaccine hasn't been offered to the men at the same time. So these sort of perceptions get attached, as Noni said. And we've also had the same issues with HPV vaccine targeting girls, adolescent girls. But we just, as Saad says, we have to be very, very systematic and scientific in the way that we deal with this in terms of where these myths come from and exploring them and then figuring out the best way to address them. What's the right communication channels and many gender aspects in that.
Mm-hmm. I think there's the why the myth keeps coming, like what is it, like why is this one keep circulating? And I have to say that people that are reluctant about immunization or maybe even anti-immunization, these start over again because I'll ask the same questions for any new vaccine that's coming down.
There is always that greatest hits repertoire that is out there.
And the infertility is one of them, is the greatest hits.
Great. So I'd like to start to wrap up. And before I pass it over to Shirin, I would just like the panelists to give a 30-second, 1 minute, what's your call to action? Actually, you've given us many recommendations going forward. But if you could really nail it down to 1 or 2 things that you feel are essential for a change in this area to really ensure that sex and gender or diversity is included in our vaccine trials to ensure better vaccine confidence. What are 1 or 2 things that you really think have to happen? Saad, I'll pass it to you first.
I'll try to do it in 15 seconds. So 2 things. First, focus on the structural interventions that I outlined already a couple of times. The second thing is, to borrow from Apurva, shame the patriarchy.
Okay, there's 2 really good articles coming out from you, Shame the Patriarchy, and the other one was The Knight in Shining Armor in Global Health. I'll look forward to reading those. Noni, over to you, 30 seconds.
get the message out there and keep asking for the answers. Why do we not know this? Why do we not know this? Why do we not know this? You just keep poking and poking and poking, and you can't give up. It's a hard thing to change, but once you change the culture and once you make it normative to know this, people are going to say, you mean we didn't know that before? You have to make it normative.
So hopefully in 5 years' time, we'll be able to tell that story. Could you imagine in 2021, people didn't actually give sex desegregated data? Can you believe it? Let's hope we get there.
That's exactly it.
Apurva, over to you.
I have two as well. And the first one I will borrow from Saad, which is to make sure that people are talking about these things in, well, actually, let me talk about the journalist part first. I think that journalists need to talk about the truth, and that's the whole truth, not just the truth as it applies to white men. And I think researchers can ask and anticipate problems more. Saad mentioned the greatest hits. You know what the greatest hits are already. So when you know that the greatest hits are coming your way for new vaccines, start early, like the anti-vax community does, a year before the vaccines arrive and not after the vaccines arrive.
Very interesting. Thank you. It's been a pleasure listening to you, and I'd like to pass over to my colleague Shirin for closing remarks. Thank you.
Great. Thank you so much for a dynamic and a very thought-provoking and stimulating conversation. I'm sure that all the participants have been enjoying it as much as I have done. I think, in conclusion, we just can say that the COVID-19 pandemic is really providing a catalyst for us to drive a more transformative change, not only with relation to the COVID-19 research, but in the broader global health research overall, ensuring inclusion of women in decision-making and development of these policies, recognizing women's agencies, not only because it's important in terms of equal opportunities, but because it's critical to make sure that these policies make sense and they work for women as well for men, as well as people of diverse gender identities and sexual orientations. We also heard that there is a lack of knowledge, but there is also some level of resistance and pushbacks, which I heard several times coming up. So we really need to think and consider how can we change and address the root causes of these resistances. We have a number of regulations and policies in favor of a gender transformative approach, but they're not being implemented. So we do need to change the culture in medicine and public health research from a more precautionary and protectionist approach to a more inclusive and intersectional and a gender transformative one. And there is both a scientific rationale, a human rights and justice rationale, but it's also economic rationale to that. And for changing the culture, we need to have a demand, and that was coming up as well. And we need the pressure from the public. There is a need to pressure for accountability. And that's where we think the media can play an important role to communicate about availability or lack of availability of evidence. So with that, I would like to welcome you to join us, create that demand. We have a call for action by Gendro, where we're calling for an urgent need to create a more gender transformative response to COVID-19 research and data analysis. So hope you can all join in and endorse that, and together we can create that pressure and create that demand to make sure that all kind of research from now on will be sensitive to the sex and gender dimensions that are important for human rights and equal benefit of everybody of the scientific development and the benefits of the science. And with that, I will thank all the participants for joining us. Most importantly, our speakers and our panelists, and Jean for a fantastic moderation. The recording of this session will be available, and please follow us and continue the conversation as we push together and mobilize our efforts to make a transformative change. Thank you so much and have a lovely day.
Thank you.